Thank you, Celso. Good morning, everybody. And I'm very honored to be here to speak at this meeting for the first time. And my topic is pancreatic adenocarcinoma downstaging and a follow-up after surgery. So going directly into the topic, you have heard from Mirko that based on cross-sectional imaging modalities, we can stage the tumor in resectable, borderline resectable, locally advanced, unresectable, or metastatic. And knowing that surgery is a curative first intent only in 50–20% of the patient. So most of the patient will be in the borderline, locally advanced, unresectable, metastatic group, while only 50–20% will go directly to surgery. And surgery followed by adjuvant chemotherapy represents nowadays the standard of care for initial resectable pancreatic ductal adenocarcinoma. And you can see here, these are the results from the CONCO study that have been published some years ago, and patients that underwent to surgery plus gemcitabine as a neoadjuvant therapy had a better survival compared to patients that went only, that were treated only with surgery. However, if we look at the numbers a little bit more carefully, we can see that overall survival at 5 years is only 20%, that most of the patients have recurrence of disease in the first years, and that when we say resectable patient, actually some of them have R1 margin resection. So this is not really good for the clinical outcome. For borderline patient and locally advanced unresectable patient, there are some issues that have to be addressed. First, the resection margin. So the aim of surgery is to obtain R0 margin. And also the identification of occult metastases. So metastases that are not seen on conventional imaging, but they are already present because one of the hypotheses is that pancreatic cancer is already a systemic disease. So in these two groups of patients, the initiation of a neoadjuvant induction therapy has its reason, and mainly to bring this patient to surgery, but not only to bring this patient to surgery with R0 resection margin. And indeed, also for locally advanced pancreatic adenocarcinoma, this is an important point, because you can see here the overall survival curves in patients that have been treated with surgery compared to patients that have not been treated with surgery. You can see that the overall survival is much better. Also compared to those patients that have the very long chemotherapeutic courses, you can see again that the overall survival in resected patients with locally advanced pancreatic adenocarcinoma is an important point. So the rationale to start a neoadjuvant and induction treatment are several points. As I told you, is to maximize the R0 resection for patients that undergo to surgery. Is also a strategy for better selected patients that have to go to surgery, because patients that will demonstrate a stable disease or a responding disease will certainly be better candidate for surgery. Is also a treatment for micrometastases, so metastases that are already present, but with our conventional imaging modalities, we are not able to see them. And another important point that has been highlighted is that in a neoadjuvant setting, this kind of systemic treatment are better tolerated by the patients. What we give nowadays to the patient is either FOLFIRINOX or a combination of gemcitabine plus nab-paclitaxel. The choice is obviously on oncological side, is mainly based on the perfusion, on the performance status of the patient. And these therapies are then may be also followed by radiation therapy, either on a long course or using a SBRT approach. And the main aim here is to decrease the risk of positive margin. So the role of imaging in a neoadjuvant setting is to assess response to treatment and also to reassess the patient concerning the resecability. As you can see here from this meta-analysis, most of the neoadjuvant treatment has been evaluated by using morphological criteria. And this is an example of a patient that have a tumor in the head of the pancreas. As you can see here, it's quite a large tumor, about 4 centimeters, that has been considered as a borderline resectable tumor based on the relationship with the vessels. And this is the same patient after neoadjuvant treatment. You can see that there is a very important shrinkage of the tumor. The patient is still considered as borderline resectable tumor based on the vascular contacts. But if we look at the vascular context, you can see here that the relationship between the tumor and the superior mesenteric artery before and after neoadjuvant treatment has not changed significantly. And this patient underwent to surgery, and the final histological report was a YPT3N1, but R1. So the first lesson to learn here is that although we can see that there is a reduction in size of the tumor because the patient responds favorably to the treatment, this reduction in size is not necessarily correlated with the R0 resection, which is the aim of the surgery. And indeed, a resection margin is an important point in this patient because you can see that the overall survival in patients that have R0 margin and those that have R1 margin, resection margin, is significantly different. This is another case of a patient that has again a tumor in the head of the pancreas, has also tumoral thrombus in the superior mesenteric vein, and this was considered as a borderline resectable tumor based on the contacts between the tumor and the vessels. And this is the CT that is performed at the end of the neoadjuvant treatment. I think that you will agree that the size of the lesion has not changed. We can still see the tumoral thrombus within the superior mesenteric vein. And this patient underwent to surgery despite the fact that there was no changes inside and no changes in vascular contact, mainly because from a biological point of view and a clinical point of view, the patient was going better. You can see here I'm showing you the changes of the CA99 from the beginning of the treatment until the end of the treatment. Then there is a very nice normalization of the tumor markers. This is also an added value to consider by addressing the patient to surgery. And indeed, she underwent to total pancreatectomy and splenectomy with a resection of the superior mesenteric vein, and the final histopathological result was a T2N0R0. So I think that you will agree if I say that CT nowadays may overestimate the tumor size of the size of the tumor, may also overestimate the vascular involvement, and it's limited in establishing the resecability of the tumor after neoadjuvant treatment. And so by evaluating pancreatic cancer response to neoadjuvant treatment based on morphological criteria is limited in pancreatic cancer. We know that the majority of patients that are treated in a neoadjuvant setting or treated also in a palliative setting will demonstrate more a stable disease more than a partial response or complete response. And this is mainly due to the intrinsic characteristic of the pancreatic cancer, because the tumor margin, the definition of the tumor margin may be inaccurate, and this is due to the fact that pancreatic cancer is characterized by an extensive dermosplastic reaction with a very important inflammation process that during the treatment, either in a neoadjuvant setting but also in a palliative setting, the fibrosis that is induced by the treatment itself may mimic the tumor tissue, and also because the morphological changes in this kind of tumor may arrive as a late event. So the current radiological criteria that we use in establishing the tumor response, in assessing resectability, and in predicting the histological response are not performant after neoadjuvant treatment in pancreatic cancer. What seems a little bit more encouraging from a radiological point of view is to evaluate the contact between the tumor and the vessels. And indeed, the regression, the reduction of the contact between the tumor and the vessels regarding the veins, so the perimesenteric vein and the portal vein, but also the artery, seems to very well correlate to the pathological response. And this is another case that we had in our institution, a patient with a huge tumor in the head of the pancreas. This is the contact with the superior mesenteric artery. You can see it's 180 degrees, while the superior mesenteric vein is completely involved by the tumor. There is also a restriction of the lumen of the vessel. And this is before and after neoadjuvant treatment. You can see that there is a shrinkage of the tumor compared to the baseline. There is a significant reduction and regression of the contact between the tumor and the vessels. And this patient underwent to surgery, and the final diagnosis was a T3N0R0. So an important point is that the imaging criteria that we have available nowadays to evaluate neoadjuvant treatment is not sufficient. So we need new imaging criteria to assess response, and also new imaging criteria that are predictive and prognostic of response, but also of clinical outcome. So we should investigate beyond morphology in the aim of identifying tissue characteristic and also physiopathological process that occur during treatment that cannot be assessed with conventional morphological imaging modalities. And for these, we have several imaging biomarkers that are nowadays available that can respond to this unmet need. And indeed, if we take, for example, the apparent diffusion coefficient that has been used as a functional imaging biomarkers in evaluating response assessment, as you can see here in a very multiple different type of cancer, what is the landmark point is that when we observed an increase of the apparent diffusion coefficient in a patient that is going under systemic treatment, this increase of the ADC corresponds to a favorable response. And we have used this approach in a small cohort of patients with pancreatic cancer, with borderline pancreatic cancer, in a neoadjuvant setting with a combination of gemcitabine, so a cytotoxic drug, and nab-paclitaxel. And what we have observed is that among the quantitative parameters that we have extracted from diffusion-weighted imaging, the D, the pure diffusion, was the parameter that changes after 2 weeks after chemotherapy in the responder group compared to the non-responder group. And the underlying explanation has to be found in the action of these two drugs, because nab-paclitaxel has been demonstrated in vivo at a preclinical study, but also at the clinical level, that is a drug that has a stromal disrupting effect in pancreatic cancer. So the combined effect of these two drugs, so gemcitabine has a cytotoxic classical effect and nab-paclitaxel has a stromal disrupting effect. Both these effect of the drugs on the pancreatic cancer is responsible of the increase of the pure diffusion that we have observed in our population. We can also use a metabolic approach in response assessment in pancreatic cancer. Here I have reported the results of two relative recent studies based on the changes of the SUV max. You can see that the changes of SUV max more than 46% seems to be correlated with a good pathological response and also with a better clinical outcome for the patient. And more recently, this study that has associated PET-MR, so they have evaluated this small population of patients, again with advanced pancreatic cancer treated with chemotherapy at an early time point, so after 4 weeks from the initiation of the chemotherapy. And what I have observed is that in the responder group, they had a reduced metabolic activity in the pancreatic cancer together with an increase of the ADC. And both these parameters, so the metabolic imaging biomarkers as well as diffusion imaging biomarkers, are very well correlated with with survival from progression-free survival, in terms of progression-free survival and also of overall survival. But using FDG PET during neoadjuvant treatment has to have some consideration. For example, this is a patient that during the neoadjuvant treatment have developed a localized hypermetabolic area within the left liver lobe, and they advanced the hypothesis this was a new metastatic disease arising in the liver. However, by integrating these imaging findings with conventional MR, with T2-weighted imaging, diffusion, and ADC, what we see that this area with moderate to high signal intensity on T2 was characterized by the presence of dilated intrahepatic left bile ducts, has this typical triangular pattern, and also had no restriction on diffusion-weighted imaging. So what we advanced as diagnostic hypothesis is that this area corresponded to perfusional changes, probably due to the fact that there was some impairment in the biliary drainage. And indeed, after the replacement of the biliary stent, what we observed is that there was a complete regression of the hypermetabolic area previously seen on PET-CT, as well as the morphological changes on the T2. So it's important in patients that have to go to surgery to evaluate the liver properly. And as you have heard previously by Mirko, it is important to perform MR, especially with diffusion-weighted imaging, and not just accept the findings on CT, because you can see by performing MR, we can change our therapeutic strategy. So using functional imaging biomarkers in assessing tumor response in a neoadjuvant setting may have a predictive role, also a prognostic role, but certainly will not give, at least with the current tools, information on the resecability of the patient. So if we have addressed some conclusion in the neoadjuvant setting, from an imaging point of view, we have to assess response and resecability, and at the moment, these two may be sometimes challenging when we are dealing with pancreatic cancer. So it's very important to integrate our imaging findings with the clinical laboratory finding and discuss this patient in a multidisciplinary team discussion to correctly address the best treatment option for the patient. Not to forget to evaluate the liver with MR and diffusion-weighted imaging to highlight metastases that are too small to be detected and characterized on CT. And I think that we should and could consider diffusion-weighted imaging or PET-CT or PET-MR when is available, also to evaluate this patient maybe in an early setting by better evaluating their prognostic impact. So knowing that pancreatic surgery is a very complicated and very complex surgery, we may account several post-surgical complications that some of them I have listed them here as major or minor complication. And this is, for example, an anastomotic fistula that have been diagnosed 7 days after resection of the head of the pancreas. You can see here the remnant pancreas at the level of the enteric anastomosis and the fluid around the anastomosis, which was very suggestive of this anastomotic fistula. This is another complication in a patient also that underwent the resection of the head of the pancreas. Again, here you can see the remnant pancreas. And you can see that the portal vein has inside the lumen a thrombus. But what is important when we are dealing with post-surgical complication is to understand if these complications have an impact on survival. And indeed, what has been recently published, that major complications themselves represent an independent factor on survival, beside the fact that patients that develop complication after surgery, they will either don't receive any adjuvant chemotherapy or a delayed adjuvant chemotherapy, and this obviously is another factor that may influence survival. Concerning the detection of tumor recurrence in this patient, based on the American and European guidelines, so beside the evaluation of the tumor markers, what is important is also to perform CT scan every 6 months for the first 2 years, according to these guidelines. But what I have seen reading recently these guidelines is that they highlight the fact that although we can perform a regular surveillance CT scan or detect at an early stage tumor recurrence, this seems not to have any benefit on patient survival. However, what I have recently seen also in the literature is that if we identify disease relapse after 12 months from surgery, in these patients have a better survival compared to those patients that the relapse has occurred before the 12 months. Obviously, these would represent tumor that have a better biological behavior. Another important point is also the site of recurrency. Most of the recurrences occurs in the liver, then followed by the local regional disease, peritoneal carcinomatosis, and lungs. And there are several factors that are associated to the site of recurrence. And this is an example of a patient that had a local disease recurrence at the level of the celiac trunk. You can see here enhancing after contrast agent with high signal and diffusion weighted imaging and low ADC values. And it's important, the site of recurrence, because the overall survival and the recurrence-free survival depends on also on this, with the best survival for the lung metastasis and the worst survival for the liver and the peritoneal carcinomatosis. So in conclusion, if we use morphological imaging criteria to evaluate patients in a neoadjuvant setting for tumor response and resectability assessment, we may be limited. However, if we see a response either represented by tumor size decrease or vascular involvement, these may be correlated with R0, may also not be correlated with R0. So these patients that have underwent to neoadjuvant treatment must be then discussed again in a multidisciplinary meetings just to address the best treatment option for this patient. And concerning the use of functional metabolic imaging modalities for disease monitoring, these should be further investigated and validated in prospective studies. We know that patients that undergo surgery in pancreatic cancer may have complications, and this can be major and minor complications. These affect directly the outcome of this patient. Based on the guidelines, we can perform tumor marks as well as CT scan on a routine basis. However, maybe these guidelines are right, these don't have any benefit on survival. But since we know that survival depends when the recurrence occurs and the site of recurrence, maybe it's worth following this patient on a much more structured follow-up. What is another point that is coming out in the recent literature is to change paradigm also concerning pancreatic cancer, since we might establish that early stage tumor recurrence should be treated as for other cancer, and this may also change the clinical outcome of the patients. Thank you for your attention.